Yeah. I'm Sanjeev Gupta. I'll be chairing this session. It's my pleasure to invite Professor Babita Ghai, who is a professor in anesthesia and pain management at the Postgraduate Institute of Medical Education and Research. I'm pleased to say that myself and Manohar, we and probably some of the other delegates in the attending the meeting, we did do our initial training in Chandigarh. We are very indebted to all the trainers there. We learned a lot from them. Babita will be discussing about her experience in setting up a pain clinic in Chandigarh and the challenges she had to face in that process. In addition to that, we are very keen to promote collaboration between the UK and other countries, including India, to see how we can work together to promote the cause of our patients and improve the pain treatments we offer to our patients. There's always something to learn from each other. We may do things differently in challenging circumstances. And in my opinion, there's always room to learn. I did visit Chandigarh in 2018, and I had a first-hand experience of how they manage pain. And it's a wonderful unit she has set up. And it's still progressing, and they're trying to develop further aspects of pain management to see how they can help their patients. I'm sure she will elaborate that in her talk. Professor Ghai is a treasurer of the pain education SIG of the IASP. She's also a member of the Developing Countries Working Group of the IASP. And she has published quite a few papers on pain management related topics. So I would like to invite Professor Ghai for her presentation.
Thank you, Dr. Sanjeeva, for your kind words. I would just share my screen and just let me know. Am I visible and audible?
Yeah, absolutely. Yeah.
Okay. So my name is Babita Ghai, as Sanjeeva mentioned, and I work at PGIME at Chandigarh. I shall be speaking on pain management. How do we do it? Challenges and collaboration. First of all, I want to express my sincere thanks to North England Pain Group, especially Dr. Sanjeeva and Dr. Manohar, for inviting me to this meeting and share my view from India. I bring greetings from Chandigarh, which is also known as City Beautiful of India, and this is the place where I work. I don't have any disclosures or conflicts of interest. As this topic is quite broad, and I would like to really share lots of experience from India. However, because of paucity of time, over the next few minutes, I shall be discussing in brief about our setup and establishing the pain clinic in PGIMER and its journey through the last decades. Few of the accomplishment, indigenous work, and striking observations observed during the last decade, and which are directly relevant to this gathering. In the second part of my talk, I shall be discussing about challenges and difficulties being faced by the low and middle income group with regard to pain management, and current and future collaborations to overcome these difficulties and challenges. Pain Clinic at our institute, which is a tertiary care academic public sector institute, was formally established in March 2009. It is a referral pain clinic which works 2 full days per week, and with 1 full day per week for the pain OT. We usually attend to around 65 to 75 patients per clinic. This is pre-COVID era, though the number is decreased during the COVID era, with the annual patient inflow of around 4,000 to 5,000 patients, out of which 40% constitute new patients and 60% are the follow-up patients. So basically, we deal with the high volume pain clinic. The minimally invasive procedures annually done are around 1,200. Patient profile seen in our setup is usually the same as seen across the globe, with chronic low back pain patients constituting around 80 to 85% of total patient population. Hence, most of our work is focused on chronic low back pain, though other modalities and other diseases are also, chronic pains are also being dealt with. With that brief and backdrop of our pain clinic, I would now like to take you to the journey of pain clinic with few accomplishments, and I'll discuss this one by one. When we started in 2009, we started as an individual healthcare provider approach. This was primarily because of the lack of awareness of pain as a specialty and a poor attitude of the other healthcare workers from the other discipline and also the lack of cooperation and getting collaborated with us. With persistent effort over the next half a decade, wherein we conducted lots of awareness programs for other healthcare workers, for the patient. We approached to what is known as a multidisciplinary approach. However, there was still a slight lack of continuity because the other disciplines did get collaborated with us. However, there were the designated team to the pain clinic was still not there. With further persistent endeavors, we reached to what we run currently as an interdisciplinary approach, wherein we have a dedicated team attached to the chronic pain. So currently we have a pain physician-led interdisciplinary clinic. The pain physicians are the anesthesiologists. So we have a essential family members, the dedicated team of pain physicians with nursing officers, physiotherapists, and psychiatrists or psychologists. These are now dedicated team who have special training in chronic pain management and who are attached to the pain clinic. The optional member of our family are research officer or any other specialty required on the need basis. The research officer is usually available whenever we have a funded project ongoing. The usual referral time for our clinic is reduced to 1 to 3 weeks over the last 3 years. This is a big achievement for us because of the persistent effort and the multidisciplinary approach and the involvement with the other disciplines. Another accomplishment during this journey is a shift from a biomedical approach to the biopsychosocial approach. Initially, the involvement of a psychologist, though the physiotherapy department is with us right from the conception of pain clinic, still the dedicated team did approach and did get assigned to us nearly in 2010 or 12. However, the involvement of the psychology department or the psychiatry department did take some time. And this was basically started as a research focus wherein the MD thesis topic was conducted to find out the psychological morbidity in a chronic refractory neuropathic pain. And the result of this research was eye-opener to the psychiatry department. And post that, they had assigned 2 dedicated team members to the chronic pain clinic. Another achievement is that whenever now our patient require physiotherapist or a psychologist opinion, they are usually being attended the same day, maximum of them 80 to 85%. And this is achieved, and if not the same day, they are attended by at least 1 week. And this is primarily being achieved by having all the clinic in this one building in different floors of the same building, wherein the pain clinic is running. We do also have a neuromodulation team in C2 with us, and with the collaboration of pain physicians, psychiatrists, neurologists, and the spine surgeons. So over this journey, you would have seen that how the collaboration with the multidisciplinary team had helped us in establishing, though we are still facing the challenges, but most of it has been overcome. So now I will talk about some of the indigenous effort which is basically meeting our local needs about low-cost nurse-based model for the first-line management, IFIT program for the module for the chronic low back pain, and we had worked about the Hindi translation of many of the patient-reported outcome. So as we are all aware that the first-line management, non-pharmacological management is essential and the most important part of management for the chronic pain patient, and self-management is paramount. While with the patient load so much in most of the developing country like ours also, the pain physicians do not find an adequate time to educate the patient about first-line management. Hence, what we have done, we have created a low-cost nurse-based or a research officer-based model wherein a group of paramedics or the nurses are trained about the first-line management using an evidence-based self-instructional module. And this knowledge and the training is imparted to the patient in the form of patient education about advice to stay active and posture advice. So this is a back care booklet which we have created and developed and validated in our setup, and which is reported to be cost-effective educational medium to promote the management of self-management of chronic low back pain. This this self-instruction module is also being translated to two local languages, Hindi translation and Punjabi translation. Most of the content is evidence-based and pictorial, basically focusing on to the less educated or the illiterate population coming from rural area. And this covers many of the aspect of the non-pharmacological first-line management. These module is available for academic use free of cost. Further step ahead for our indigenous work is constitution of an integrated approach of yoga therapy, wherein a module is being developed by PGIMER in collaboration with Swami Vivekananda Institute of Yoga, which is an institute of repute. The effectiveness of IFYT module is being also checked in one of the randomized pilot trial, and we are about to conduct a complete trial of the same. This module is basically focusing on to the biopsychosocial aspect of management for chronic low back pain, starting from opening prayer to asana, to deep breathing exercises, pranayam, and meditation. This particular module is taught to the patients either in group or individual, offline or online, for 3 to 5 settings or maybe 5 to 7 settings by a trained yoga therapist. And finally a pamphlet of this module in different languages, whatever patient can understand, along with the complete WhatsApp audio of this session is provided to the patient, and this has shown promising results. We have also worked towards the developing local languages, that is Hindi translation of many of the patient research, patient reported outcomes with regard to chronic pain, and validation of the same has been done, and the same has been published in various journals. Again, these are all available. These resources are available for academic use free of cost. I would like to also mention a striking observation, which I would like to share, is that over the initial periods of our management, we realized that whenever we started with the recommended doses of neuropathic pain management, then many of our patients did report a very high serious adverse event, as high as in 40 to 50% of the patients, so serious that had led to the interruption or discontinuation of the treatment, even in the younger population. This was not focused to the older population. So this led to a lot of dissatisfaction in the pain management of these refractory neuropathic patients. So we reached to a consensus and we made an institutional protocol that now we started lower doses of TCA or gabapentinoids as an initiation dose, and the doses are escalated depending on the effectiveness and the side effect profile of the drug. This observation of R is further strengthened by a recent publication wherein a survey was conducted by Medical Affairs Department of Bogard Limited, where they surveyed 281 doctors across 30 cities of India and about the uses of initiation and maintenance doses of TC and gabapentinoids. And this was basically conducted because they noted during the Indian market survey research, they noted that the low dose packs were sold more in India. So then during the result of this survey reported that 70 to 87% of these physicians were using lower doses of TCA or gabapentinoid, 5 to 10 milligram per day of amitriptyline, 50 to 75 milligram of per day pregabalin, and 100 to 300 milligram per day of gabapentine for initiation as well as for the maintenance dose. So why do we observe this? And does this have relevance to, of sharing to this forum? I would say yes. Probably with the Indian body size is smaller than the international body size, and that probably is the reason, one thing. Or the Indian patients may perceive the pain differently or respond to the treatment in a different manner. There might be cultural differences, or this might be because of differences in phenotype or genotype, as was discussed in detail in the morning lecture by Dr. Srivastava. Why am I discussing these all work or the striking finding is because that I understand a sizable population of UK patient population is formed by either by the Indian or the Asian population. And I would also like to get insight to that this neuropathic, this North Indian pain group has also experienced such type of observations that the patient respond to the lower doses of neuropathic pain medicine. So moving on to the second part of my talk, that is challenges and difficulties during this journey, which are also being faced by the low resource countries overall. So pain is a neglected problem in low resource country, and the reasons for this are multifactorial, related to patient, healthcare professional, government's policy, or the drug availability or the scarcity of the drug. So with the most of the time we see poor patients which have poor health literacy, may have an opioid phobia. Also the patient, we are overloaded with the work, and we see the high volume load patients, and we work in the resource crunch area. The governmental policies are focused more onto the other communicable diseases or the other diseases like HIV or AIDS, and the commissioning to the pain is usually not given a priority. Also, when the world is seeing, Western world sees the one end of the opioid crisis, that is overuse or the misuse of opioid. We in India or in the low income middle group country, we see the other end of the crisis, that is the limited availability of opioid or the scarcity of the opioid. India, being the fourth producer of opioid, still consumes morphine very negligible. This is low at the 0.5 milligram per capita is the consumption of the Indian population. And in fact, the opioid are not even available for the palliative care in India. So another aspect which I just mentioned, that there is the challenge about the patient, about the structural pain educational program. Pain education is not very well developed in low middle income groups, and the same is true for the India. We have very countable fellowship programs which can be counted on figures and on the fingers. And there is just very recently a 3-year DM program in pain management was started in AIIMS Patna. ISSP, that is Indian Society for Study of Pain, has taken advancements in this regard, and they had created Indian Academy of Pain Medicine wing, which is an academic wing, and which has started a structural pain training program with elaborative curriculum with 1.5 years of fellowship with entry and exit exams in selected centers, accredited centers. However, this fellowship still has to see the endorsement of national health body, that is either the National Medical Commission or the MCI. So what is the way forward to overcome these challenges and difficulties? I would say collaboration is one of the way forward. A mutually beneficial collaboration in front of academic, clinical, research and quality improvement fronts is one way to overcome a part of the challenges and difficulties of pain management. The aim of the collaboration should be to share and learn from each other on a common platform. The collaboration should be mutually benefited. Collaboration between a developed country and a developing country can be established. The collaborating partner who, whatever they have more experience or they have expertise, can be shared with the other partner. Like a developed country collaborator can share on the academic fronts, which we are seeing in this current meeting today. We are also sharing, we have learned, I am sharing my experience, and we have learned quite a lot from the other speakers in this forum. The procedural or equipment advancement can also be shared, as was also been shared in detail by, I would say, a lot of e-tool was discussed by Barani and many others, and this can be learned. A registry development can also be established with the help of a developed country partner to assess the outcome of the common interventions which are being conducted in both the countries. And research, especially the basic research, is very difficult to find. Funding for the basic research is difficult to find in developing country. That can also be shared or can also be collaborated on that front. While a developing country partner have a huge experience, clinical experience by the mere number of the patient overload, so they can share their clinical expertise and especially working in the effectively in the resource crunch conditions, and this can be adapted in the other areas. Dealing with the less educated population, they can also share that experience. The low-cost models can also be shared, as I just discussed, a few of my effort, a few of our team effort, and this can be developed, this can be shared according to the local need. As the patient load is pretty high in developing country, the clinical research or the translation research is usually faster in a developing country if the funding is received. With the current scenario of the COVID area, it is definitely a challenging scenario. However, it has provided us the opportunities of going virtual. So it is easier to collaborate and share, and this collaboration is just one click away. And one of the example is this meeting, which is open to the whole globe, and we are seeing delegates from all across the country and collaborating and sharing their experience. I'm sharing my experience from India, and I'm gaining the insight to the North England Pain Group or the UK group. So So this collaborations can benefit whenever virtual mode, whenever we go offline, we can also go into the offline mode. So now I would like to share some of the collaboration which has benefited both the parties. One the morning I had read the question about how is there any academic program or a training program in UK. I would just like to share that there is Commonwealth Academic Staff Fellowship, under which a home country delegate from any of the Commonwealth country can apply to the 4 of the host country institute of UK, and they can get training in 3 to 6 months in various academics post, and pain management is one of that. This opportunity, this collaboration provides the opportunity to both the parties, and this leads to bilateral gain. I have been the one of the recipient in 2012 for the same. What happens that the delegate from the home country or from the low middle income company group country, they receive the expertise and experience in clinical management or the research management, working at 3 to 6 months in the host country in UK, and the host institute in UK get a trainee for 3 to 6 months without having any financial bearing, because all the finances are borne by the British Council. So how I participated and got benefited, that I got the experience and expertise for 6 months, and then applied into the home country to India and improved the patient outcome. I participated in the research work which is published in BJ, and I also contributed e-knowledge library to the Pain Out Registry in UK. Another Indo-UK collaboration I would like to highlight is Global Update Pain at Mumbai, which was an international event, and I see the smile on Sanjeeva's face for this, which was an international event held every 3 years. The collaboration from the UK, especially the North England group and Indian pain practitioner, was established, and this event held from 2001 to 2015, and there was a bilateral exchange of thoughts and clinical experience and expertise in this. We have also had very recently visits to PGI MER from the North England group. Dr. Manohar Lal in the year 2016, 2017, and 2018, Dr. Manohar, Dr. Sanjeeva, and Dr. Vivek had visited us, and we had exchange of thoughts of various aspects of chronic pain management, chronic pain covering various aspects, cancer, chronic, and neuromodulation. There has been a recent collaboration, that is EPIN course, which is the European Executive Program in Neuromodulation, that is William Harvey program, which held in last month, and the course director for which is Dr. Vivek Mehta and Dr. Kavita Popley. This was an online course on curriculum covering all aspects of neuromodulation. It was a half 6 days session over the weekends. Faculty across the UK and India collaborated for this program, and 42 candidates across the globe had an interactive session, and the second course is due in September 2021. And this is basically the basis for the further proposed collaboration of full master courses in the future. Pain Out Registry is another very important collaboration front for the quality improvement of postoperative pain management. This is a registry which is funded by European Commission and IASP. It is a web-based registry wherein the different participants can participate using the questionnaire-based assessment on the web, and they can have feed their input, and this provides the improvement of the postoperative pain management in their setup. The questionnaires are available in more than 20 languages to be used across the globe. Collaborations have also been conducted by various other organizations, that is IASP country chapters, WFSA, that is World Federation Society of Anesthesiologists. They have a pain management wing. WHO Pain Relief Foundation and Indo-UK collaborations are also there. On the IASP front, IASP has a developing country working group grant, which is provided to the developing country candidates to conduct a 1-year pain education program in their setups in their country. And the grant up to $10,000 US dollar is provided. Recently, IASP has also started a new initiative, that is pain camps and pain schools, to attract the newcomers in the field of pain management from Asian and ASEPS countries. So I would say persistent efforts are needed and welcomed for future collaboration across the globe to overcome the difficulties and challenges being faced in the chronic pain management or pain management overall. The collaborations should be beneficial to all the collaborators. It can be done virtually, which makes the things easy, but however, whenever possible, when we go to the offline, it can be done on offline. This can be done on educational front, as we are doing currently, conducting academic meetings and sharing our experience. On clinical fronts by sharing the clinical experience and the case discussion for the challenging cases. On research front, by starting a research on the collaborating front, and by checking whatever, looking for the pain practice of the different region. And on the quality front, by developing a research registry to assess the outcome of the common interventions. Hence, I would say pain as a specialty in low middle income group has progressed and advanced in the last 2 or 3 decades. However, a lot still needs to be achieved, and this can be achieved by a mutually beneficial collaboration, a robust mutually beneficial collaboration. Thank you for your kind hearing. I'm willing to answer any query.
Thank you, for your excellent talk and finishing on time as well. We have a few questions. The question is, who refers you the patients? Is it the local doctor or the specialists such as orthopedics and neurology?
We have referral from various specialty. So I would can I stop sharing my screen?
Yeah, that's fine.
Yeah, so we have, as you've seen the patient profile, the primarily referral physicians are orthopedicians, neurologists, neurosurgeons, gynecologists for the pelvic inflammatory diseases, fibromyalgia, or the rheumatologist for various other their ankylosing spondylitis rheumatology, or the neurologist for the migraine. So we have various multidisciplinary physicians referring to us. Primarily, they are from our institute, but that is not restricted only to our institute. We do get referral from the corporate sector, from the private sector, or as I just mentioned that our institute cater to nearly 5 states across 5 northern states of India, catering to 500 million population. So we do get referral across the states also. So various specialty you name, the post-surgical persistent pain is referred by the surgical specialty.
No, we get that. The next question is, you said that you see about 60 to 65 patients in a clinic. Are you alone or are you with some trainees?
We are usually 2 consultants on Wednesdays on a full working day. And we have trainees who are registrar who are doing training under us. So usually 2 junior resident along with us. We do have a nursing officer, and most of the time paraclinical staff, that is a pharmacy student who is deputed with us as a research officer is with us. But as we do not get senior registrar or the senior resident, but we call it post-training registrar in our setup, the consultant has to see all the patients, even if seen by the junior registrar.
Okay. There is a comment, 1 or 2 comments which I'll read out. One of the delegates informs that Indian experts from developed countries can contribute for education while they're on vacation in home country. I think a good number of them do that already. Maybe we can do that a little more if possible. It can be anything, India or any other country for that matter.
Yep.
Other question is there a pain fellowship course going on in UK for Indian pain physicians? What is the eligibility criteria? I think there is something called as a medical training initiative. I've known that some doctors have come through that from various parts of the world. That may be the best option at the moment from what I know. Unless anybody else has any comments, they can share their ideas if appropriate.
Okay. I'll also, MTI is one thing which you said, definitely. That is basically prolonged training, which can be the candidates to get a fellowship of either 1 or 2 or 3 years in the MTI course. But what I talked about is academic staff fellowship. That is from the Commonwealth, that is granted by the UGC and Commonwealth together. That is one short-term training which candidates can receive for 3 to 6 months. And this is not just provided in pain management front, it is provided in all the discipline across. The only eligibility criteria is that the candidate should be from the public sector and should be in the mid-career age where they can benefit to the home country, and the candidate should return back to the home country after achieving the training.
So, you also mentioned about the lower doses of amitriptyline and gabapentinoids for neuropathic pain in your experience.
Yes.
In my experience also, I work in Bradford. We have a reasonably big Asian population. I would your suggestion. Having said that, there is also a comment here that we have done a survey on gabapentinoids in North Midlands in the UK, and we had found the adverse effects to be around 40%. So maybe we need to go lower doses internationally for neuropathics, but this can be debated. It's individual experience as well. And you also mentioned about opioids, non-availability of opioids for cancer pain.
Yes.
How is that being addressed?
This is non-availability of or the scarcity of opioid is primarily because of the tight NDPC law, that is narcotic control law. This is basically very big challenge, and ISSP along with IAPC, that is India Academy of Palliative Care, have had discussions with the governmental, the governance and the governmental individuals to ease out those law which has been functional since 1985 and very tight law. This is basically they had also approach to the government authorities to ease out the law based on the and the more of the authorities to be given to the states. So if a state feels that the particular state has a more abuse potential, illegal abuse potential, they can have their stringent law, while the other states can have some of the law and the leniency in their law. So if you see, Kerala has done beautifully good in the IAPC front, and the availability of opioid is primarily because of a lot of effort being taken by the team working over there. However, Punjab, the northern area where I work, we have still the tighter the legislative policies, because our area is like, especially the Punjab, has more of abuse potential. However, still we lack the reaching to the northern, reaching to the rural area is very difficult, and many we still face the challenges. More of the palliative care the clinics are being also opened up.
Yeah. There's also a comment by one of the delegates saying that they do have, this is probably from India from what I can see, we do have immediate release morphine, sustained release morphine, fentanyl patches, methadone available now in India. So obviously there is a difference in availability in different states of the same country. Thank you very much, Babita, for your talk. And as you mentioned in your talk, I think one of the reasons we wanted you to present was to see how we can collaborate with, how the North England Pain Group can collaborate with pain clinics across the world and also India. So what we would like to consider is, if anybody is interested in collaborating with the North England Pain Group, then if they can get in touch with Lorraine, and we can see how we can sort of facilitate that. I'm sure there are other bodies which may be willing to collaborate as well, but I can't speak on their behalf. As far as the North England Pain Group is concerned, we will be keen to collaborate in whatever way we can, so that we can mutually benefit from the collaboration. Thank you for your talk, Babita.
Thank you. Just a last comment, Sanjeeva, as I believe that definitely India is a very heterogeneous country. So experience over here is, we have to keep it in mind, this is from a tertiary care experience. And we do face lots and lots to be achieved at secondary and primary level regarding the pain management. Thank you.
Thank you. Our next speaker is Chris. Before I go to the next speaker, can I go? Chris Haley. Chris Haley is a pain specialist in Kingston Health Sciences Centre in Canada. He trained in medicine in St. Andrews University, Scotland, as well as Manchester.